Okay, welcome back to the deep dive. Today we're diving into a topic that touches a lot of people, often in ways we don't fully appreciate until we look closely. Tinnitus.
Hmm.
We've got something special for this deep dive. We're working directly from a stack of your revision notes, specifically focused on tinnitus.
Exactly. Think of us as your guides through these notes. Our mission is to unpack all the key information here, distill it into those high-yield insights you need for revision, and make sure you feel totally clued up on tinnitus, ready to tackle any question.
All right, let's get stuck into these notes and really master the essentials of tinnitus.
Let's do it.
So right at the top of the material, the fundamental definition. When we talk about tinnitus, what exactly are we talking about?
Well, at its heart, tinnitus is the perception of sound when there's no external source making that sound. It's a sound generated internally,
Okay.
and it can be perceived in one ear, both ears, or sometimes even feels like it's coming from inside the head.
And the notes are clear that it's not just one type of sound, right? People hear different things.
Definitely not. The common descriptions you'll see are things like ringing, buzzing, hissing, or sometimes a roaring noise. People experience it in different ways.
Okay. One crucial distinction the notes make early on is between subjective and objective tinnitus. What's the key difference there?
Yeah, this is a really important point. Subjective tinnitus is by far the most common type. This is where only the person experiencing it can hear the sound.
Right.
When someone says, "I have tinnitus," this is usually what they mean. Now, the notes flag something vital here. Subjective tinnitus is sometimes mistaken for an acoustic neuroma.
Ah, okay, the tumor.
Exactly, a type of benign brain tumor. But the notes immediately provide context, and this is key. Acoustic neuromas are incredibly rare compared to tinnitus.
How rare.
Like 1 per 100,000 people each year. Tiny numbers. And even with an acoustic neuroma, it more commonly causes unilateral hearing loss. Tinnitus being the initial or only symptom happens in maybe 2% of cases. So subjective tinnitus is common, but subjective tinnitus caused by an acoustic neuroma is actually really rare. That's a high-yield fact to keep in mind.
That really highlights how important it is to put things in perspective.
Uh.
Okay, what about objective tinnitus? This is the rarer type you mentioned.
Right, and it's fascinating because the sound in objective tinnitus is physically generated within the body.
So it's real, in a sense.
Yeah, and sometimes a clinician using a stethoscope might actually be able to hear it. The notes break this down into specific subtypes based on what's causing that internal noise.
Okay.
First, there's pulsatile tinnitus. Often sounds rhythmic, like a heartbeat or pulse.
Like a whooshing.
Exactly. This type is frequently linked to blood movement, and the notes give examples like narrowing of the carotid artery, carotid stenosis, or certain vascular anomalies or tumors.
Makes sense.
Then you have muscular or anatomical tinnitus. This is caused by movements or structures in or around the ear. The notes mention things like palatal myoclonus, involuntary spasms of the soft palate, or spasms of the tiny muscles in the middle ear, or even something called a patulous eustachian tube, where the tube connecting the middle ear to the back of the nose stays abnormally open.
Right.
And finally, the notes list spontaneous objective tinnitus, giving otoacoustic emissions as an example. These are tiny sounds produced by the cochlea, the inner ear, sort of as a byproduct of its normal function.
You can measure those.
Sensitive microphones can sometimes detect them, yeah.
That clear breakdown helps frame the different ways tinnitus can manifest. So moving on, what are the causes, or etiology, listed in the notes? It seems like they start with a general overview before getting specific.
Exactly right. The notes give us a broad strokes view first, listing common general causes. These include exposure to loud noise.
A big one.
Definitely. Age-related hearing loss, which is also called presbycusis, even something as simple as earwax blocking the ear canal.
Mm-hmm.
Certain medications, which we'll come back to in more detail, ear infections, ear or head injuries, and conditions like Meniere's disease.
Okay, those sound like the usual suspects for ear issues. Then the notes get more specific about particular conditions linked to tinnitus.
Yes, they provide a more detailed list of specific causes. Idiopathic tinnitus is listed. That just means there's no identifiable cause.
Which you said is common.
Yeah, actually quite common, especially for subjective types. Meniere's disease is mentioned again, but here the notes highlight the classic package of symptoms: hearing loss, vertigo, tinnitus, and a feeling of fullness in the ear.
The quartet.
Spot on. Otosclerosis is listed, linking it to conductive hearing loss, tinnitus, and often a family history. Sudden onset sensorineural hearing loss, or SSNHL, is noted as a cause. Acoustic neuroma comes up again, linked specifically to neurofibromatosis type 2.
Yeah.
Hearing loss in general, whether from noise or age, is a specific cause. Drug-related causes get a dedicated mention, and the notes list specific culprits you really need to know. Aspirin and other NSAIDs, aminoglycoside antibiotics, loop diuretics, and quinine.
Those are important ones to remember.
Definitely. And finally, impacted earwax is listed as a specific visible cause, something you can see with an otoscope.
That's a lot to keep track of, but breaking it down helps. And the notes organize this further by the type of tinnitus subjective versus objective causes.
They do, which is useful for revision. For subjective tinnitus, the causes are grouped. Otological causes related to the ear itself, like noise damage, presbycusis, otosclerosis, infections, Meniere's.
Okay.
Neurological causes like head injury, multiple sclerosis, or tumors, though remember the acoustic neuroma point.
Right, rare but possible.
Infectious causes like meningitis or syphilis. Drug-related causes are repeated here with the same examples. Salicylates, NSAIDs, aminoglycosides, diuretics, cytotoxic drugs, and even jaw disorders, specifically temporomandibular joint dysfunction, or TMJ, can be a cause. And importantly, the notes reiterate that for subjective tinnitus, often no cause is found. It remains idiopathic.
Okay, and for the less common objective tinnitus, the causes directly link back to those subtypes we discussed earlier.
Precisely. It makes logical sense. The causes for objective tinnitus mirror the subtypes. Pulsatile noises are linked to blood flow issues, carotid stenosis, tumors.
Got it.
Muscular or anatomical causes point to structural or movement issues, palatal myoclonus, tympanic muscle spasm, patulous eustachian tube. And spontaneous causes like otoacoustic emissions. It's a logical progression from definition to specific causes.
So, who is more likely to develop tinnitus? What risk factors should we be aware of from these notes?
The notes list the key risk factors quite clearly. These are significant exposure to loud noise, that's probably the biggest modifiable one. Advanced age, which we saw reflected in the prevalence data. Male gender is listed as a risk factor.
Interesting.
Existing medical conditions like pre-existing hearing loss or cardiovascular disease. And the use of ototoxic medications, those are drugs known to potentially damage the ear.
Right, the ones you listed earlier.
Exactly.
The notes also touch on the pathophysiology, essentially. How does tinnitus actually happen in the brain or ear? What's the current understanding, according to these notes?
Yeah, the notes are clear that the exact how isn't fully understood yet, which is important context to have.
Still some mystery there.
Definitely. However, the prevailing theories outlined involve changes happening within the auditory system. Specifically, they mention abnormal neural activity in the auditory pathways.
Like misfiring.
Kind of, yeah. Essentially, nerve signals firing when they shouldn't be. And also altered functioning of the hair cells in the inner ear, which are responsible for detecting sound vibrations. It's thought the brain might be reacting to damaged hair cells or maybe altered input from the ear.
Okay, that makes sense. Now, when someone comes in with symptoms that sound like tinnitus, what else could it potentially be? What other conditions are in the differential diagnosis according to these notes?
This is a critical step in assessment, ruling other things out. The notes list conditions that can present with similar symptoms and need to be considered. These include middle ear infections.
Otitis media.
Right. Meniere's disease, acoustic neuroma, though remember how rare it is to present as tinnitus alone. Temporomandibular joint, TMJ, disorders, and certain vascular conditions, especially if the tinnitus sounds pulsatile. These are important to rule out because they often have specific treatments, unlike, say, idiopathic subjective tinnitus.
Got it. So how common is tinnitus? What do these notes tell us about its epidemiology, its prevalence?
The notes primarily give us statistics from the UK. They state it affects a significant portion of the population, somewhere between 10% and 15%.
That's a lot of people.
It is. And it's definitely more common as people get older.
Okay.
The NHS estimates are broken down further, which is useful for understanding the impact. About 10% of adults experience it at some level, but the numbers shrink as the impact increases. Maybe 2.8% find it moderately annoying, 0.1%, 0.6% find it severely annoying, and about 0.5%, 0.5% say it significantly disrupts their daily life.
A smaller group, but still significant suffering.
Absolutely. The notes also mention that a similar prevalence is seen in children, which might be surprising to some.
That age jump really stands out, though, doesn't it?
It really does. The notes show it's relatively low in young adults, maybe around 5% for ages 20-30, but it more than doubles to 12% in people over 60.
Wow.
The notes also highlight a strong link to depression, stating a prevalence of 33% in people with tinnitus.
A third. That's high.
It is. The link to suicide is mentioned as controversial. NICE guidelines recommend crisis referral for high-risk cases, which makes sense. But the notes point out that the literature review on a direct causal link between tinnitus and suicide is actually inconclusive.
Okay, important distinction.
Okay.
So someone comes in describing these sounds. How do they typically present clinically, and what examination and investigation steps are outlined in the notes?
Well, as we've covered, the core presentation is the perception of sounds like ringing or buzzing in one or both ears. A practical tip from the notes is using questionnaires like the Tinnitus Functional Index.
They measure impact.
Exactly. To assess how much impact it's having on their life, it's not just about hearing the sound, but how it affects them day to day.
Makes sense.
For examination, the notes suggest a thorough check of the head, neck, ears, and jaw. You're looking for physical signs like earwax blockage.
Simple things first.
Right. Listening for carotid bruits with a stethoscope, especially if it's pulsatile tinnitus, checking cranial nerves, feeling for any masses. A hearing test, an audiological assessment, is strongly recommended.
Always check hearing.
Almost always, yeah. And tympanometry might be useful if hearing loss is suspected. The notes also add a little detail to check for whether the person is taking hypertension medication, as this can sometimes be relevant.
Good point. And when it comes to investigations, this is where the notes get quite specific, especially differentiating based on the type of tinnitus, pulsatile or not.
Absolutely. The initial approach is always based on the history and clinical findings. The hearing test is fundamental to check for underlying hearing loss.
Okay.
But for imaging, the path really diverges. For non-pulsatile tinnitus, the key message from the notes is generally no imaging is needed.
Really?
Yeah, unless there are other concerning symptoms, like neurological signs, or if the tinnitus is clearly unilateral or asymmetrical, if imaging is deemed necessary for non-pulsatile tinnitus.
Then what?
The first-line investigation recommended is an MRI of the internal auditory meatuses, or IAM. The notes specify that imaging might be considered for persistent unilateral or asymmetrical tinnitus, even without other symptoms, but symmetrical non-pulsatile tinnitus typically does not require it. That distinction is important for revision.
Okay, so not everyone needs a scan. What about pulsatile tinnitus?
That's different. The notes strongly recommend imaging here because there's a higher likelihood of finding an underlying, potentially treatable vascular cause.
Right, the blood flow link.
Exactly. Magnetic resonance angiography, MRA, is often used. The notes provide specific imaging pathways for pulsatile types. For synchronous pulsatile tinnitus, pulsing with the heartbeat MRA or MRI is the starting point.
And if that's clear.
If those are normal or not feasible, a contrast-enhanced CT might follow, and potentially a contrast-enhanced CT of the temporal bone. For non-synchronous pulsatile tinnitus, MRI or contrast-enhanced CT of the head is suggested.
Quite detailed.
It is. The level of detail highlights that pulsatile tinnitus requires a more aggressive investigation approach compared to non-pulsatile.
That's a really clear guide on the investigation pathway. So, once you've assessed and investigated, how is tinnitus typically managed according to these notes?
Management focuses on two main goals. One, addressing any identifiable underlying cause if possible.
Like wax removal or treating an infection.
Precisely. And two, crucially, helping the person cope with the symptom itself and its impact on their quality of life. Because often there isn't a cure for the sound itself.
Okay, so what are the general approaches?
General management approaches listed include investigating and treating those underlying causes. If there's associated hearing loss, amplification devices like hearing aids can often help with both the hearing and the tinnitus.
Ah, it's interesting.
By amplifying external sounds, it can make the internal tinnitus sound less prominent, less noticeable. Psychological therapies, particularly cognitive behavioral therapy, CBT, are also recommended.
For coping.
Yes, for changing the way you react to and think about the tinnitus. And joining tinnitus support groups is also listed as a helpful strategy. Sharing experiences can be really valuable.
Are there any specific general measures highlighted for just coping day to day?
Yes. The notes mention tinnitus support or counseling. Using relaxation techniques or background music or sound generators as sound enrichment can also be beneficial, basically giving the brain something else to focus on.
Distraction.
Sort of, yeah. For someone experiencing persistent distress from their tinnitus, the notes recommend referral for digital CBT, group-based cognitive therapy, or individual tinnitus-related CBT. Now, here's a key negative recommendation from the notes. Tinnitus retraining therapy, or TRT, is not recommended based on the evidence reviewed.
Okay, good to know what not to do.
Exactly. They reiterate amplification devices for those with both tinnitus and hearing loss. And they mention sound therapy, like masking devices, but note that more research is needed on its effectiveness.
What about medication?
Mhm.
Is there a pill you can take to make tinnitus go away? The magic bullet.
This is a critical point for revision, and the notes are very clear and definitive on this. No specific pharmacological therapy is recommended for tinnitus itself due to insufficient evidence.
Really? None at all?
None recommended specifically for the tinnitus sound. This is a high-yield fact to remember. The notes list various drugs that have been tried in studies: anti-vertigo drugs, antidepressants, anticonvulsants, anxiolytics, even intratympanic injections, and supplements like ginkgo biloba, melatonin, and zinc. But the bottom line from these notes is the evidence isn't strong enough to recommend any of them specifically for treating the tinnitus sound itself.
That's huge. So it's really about management and coping, not medication cure.
For the most part, yeah.
And surgery. Is that ever an option?
Surgical treatment for tinnitus is very rare. It's really only used if the tinnitus is caused by a specific underlying condition that can be surgically treated.
Like the acoustic neuroma.
Exactly. The example given is removing an acoustic neuroma if that was the identified cause. You wouldn't have surgery for the tinnitus itself, only for the rare treatable condition driving it.
Got it. The notes also include important referral guidelines. Knowing when to refer someone is crucial.
Absolutely. The notes give clear triggers for different levels of referral urgency. Immediate referral, like emergency department or immediate specialist contact, is needed for someone with high suicide risk.
Right, linking back to the potential distress.
Yes. Immediate referral also for certain new neurological symptoms appearing alongside the tinnitus, uncontrolled dizziness or balance problems, vestibular symptoms, or suspected stroke.
Urgent red flags.
Definitely. Referral within 24 hours is specified for tinnitus presenting with sudden hearing loss that needs rapid assessment. Referral within 2 weeks is recommended if distress persists despite initial support, or for sudden or rapidly worsening hearing loss that wasn't immediate onset. More generally, referral should be considered for tinnitus that's bothersome, any persistent objective tinnitus, tinnitus associated with hearing loss that needs further assessment, or pulsatile tinnitus. The notes specifically add considering referral for any persistent pulsatile tinnitus or persistent unilateral tinnitus, even if initially investigated and thought to be idiopathic. Basically, don't ignore persistent unilateral or pulsatile symptoms.
Good safety netting advice. How does tinnitus typically progress over time? What's the prognosis like based on these notes?
The notes describe tinnitus as often being a chronic condition, meaning it can persist for a long time, and its severity can fluctuate, it can vary.
So it might not go away.
Often it doesn't completely disappear, no. The outlook, the prognosis, is influenced by whether an underlying cause is found and treated, and how effective the coping strategies are for the individual. However, the notes do offer a glimmer of hope. They mention that some cases can improve or even resolve on their own over time, although it's quite unpredictable who that will happen for.
Okay. And finally, while tinnitus is a symptom, it can lead to other problems, right? What complications are associated with it according to the notes?
That's right. The notes reinforce that tinnitus is a symptom, not a disease entity in itself, but they clearly state that it significantly impacts a person's quality of life. The listed complications are a direct result of that impact. Significant distress, anxiety, problems with sleep, so sleep disturbances, and difficulties with concentration and focus.
That sounds debilitating.
It can be. These highlight why managing the impact of tinnitus is just as important, sometimes more important, than just looking for a cause that might not even be there.
So pulling all of this together from your notes, you can see tinnitus is much more than just hearing sounds. It's got this range of types, subjective, objective, numerous potential causes, from the simple, like earwax, to the rare but serious, like certain tumors or vascular issues.
Right.
And critically, it can have a profound impact on someone's well-being, even if it's just a sound they perceive.
Exactly. Navigating these details, understanding the subjective versus objective distinction, knowing when investigation is needed, especially for pulsatile types, remembering there's no magic pill.
To a point.
And recognizing the importance of supporting someone's mental health and ability to cope. These are the key takeaways. These notes really help clarify for your revision.
Thinking about everything we've just unpacked from these revision notes, isn't it fascinating how something that's defined as a purely subjective perception, a sound only you can hear, can lead to such profound, objectively measurable consequences like documented sleep loss, anxiety scores, and difficulty concentrating.
Yeah, it really shows the intricate link between perception, the brain, and our overall well-being, doesn't it? How something internal can have such significant external effects.
Absolutely. And that wraps up our deep dive into your tinnitus revision notes. Hopefully breaking down these key facts, types, causes, investigations, and management approaches helps solidify your understanding and makes you feel much more confident.
We've aimed to pull out the essential points covering definition, causes, risks, pathophysiology, differential diagnoses, epidemiology, clinical features, investigations, management strategies, prognosis, and complications, straight from your source material framed for high-yield recall.
Remember, staying well informed is absolutely key for revision success.
Definitely.
For more resources to support your revision and learning, you can explore pastemsra.com and freemsra.com.
Great resources there.
Thanks for joining us for this deep dive.